Just a yes or no question, just so we have you guys on the record. As we go across, starting with you, Mr. Hassan, are you for Medicare for all, just so all of our colleagues here know that?
No.
Okay. Mr. Laster?
No, sir.
Donnelly?
No.
Waldron?
No.
Woodhouse?
It's not a yes or no question.
Nice answer. Every one of us here today have heard from our constituents expressing the concern over rising health care cost. Since 2000, hospital prices have grown nearly 300%, vastly outpacing inflation and wages. In fact, hospital prices have grown more than any other part of our economy, and no one really knows how these prices are calculated. While most individuals are not directly exposed to true hospital prices, these are not just abstract costs in the ether. These costs are passed directly on to patients, whether it's in the form of cash prices or higher premiums or out-of-pocket costs. I would like to follow up on some of my colleagues' comments regarding site neutrality or the lack thereof. The reality is that federal payment policies and billing practices such as site of service pricing have enabled wide variation in prices that often bear little relationship to the actual cost or quality of care. Hospital systems being allowed to charge more for the same services has led to consolidation in the system, with hospital systems steadily acquiring more independent physician offices and outpatient facilities, reducing competition. Data has shown that when hospitals acquire physician offices, patients pay up to 4 times more than the same exact service done in the same exact place by the same exact doctor. I have one CEO said, I can't explain why that is allowed, but that's just the way the system works. And again, this is not just a data game. I've heard from patients directly in my district that have seen this happen and want answers. Their doctor hasn't changed, their health status hasn't changed, the building hasn't changed, just the ownership changed and the price. For all of the witnesses here today, if you all won't commit to supporting site-neutral payment policies, how will you ensure patients will not be subject to price increases at their physician offices after they are bought up by your hospital systems? Any thought, Mr. Donnelly, Dr. Donnelly?
I just think, say, as a strategy, we do not purchase physician practices and turn them into hospital sites. That's not a part of our strategy.
I would say the same thing.
I would concur with that, Congressman, that we do not buy practices to convert them to site neutral.
Mr. Hassan?
We don't do that at all.
Okay. So continue on the disparities between independent physician offices and hospital systems. I want to talk about tax status. Many large health systems operate as tax-exempt entities and are subject to the same requirements to maintain their tax-exempt status as independent providers. Given the differences between these large corporate health systems and smaller independent providers, I imagine the IRS reporting varies as well. Dr. Donnelly, solo providers report their community benefits spending based on its individual facility. Do large systems like New York Presbyterian report community benefits spending on a facility-by-facility basis, or does the hospital report all of the community benefits spending across all the facilities on one Form 990?
We report, following the federal guidelines, as one facility.
Okay. So how can the IRS determine if an individual facility is satisfying the community benefit standard if no information is reported about the community benefit spending by the individual facility?
I think that would be a discussion we'd be happy to have. As I said, right now, the federal guidelines have us reported as one facility.
So you would have no problem then being able, a very large system, if you're in a rural community or outlying community, you'd have no problem reporting a different 990 for that particular area as you're looking at how your community benefits compare to some other independent provider.
I think it would take a lot of work. We'd have to work through that to see what the process is.
But it would probably be well worth it for a tax-exempt status, right?
I think tax-exempt status is very important. We have a $2.4 billion community benefit. Our tax-exempt status is a benefit of $622 million. So our community benefit right now is 4 times what the tax-exempt status is for us.
Yeah, you would. I obviously haven't looked at your financials, and I'll take you at your word since you're testifying here. But that's not the case for all. When you look at the tax-exempt benefit for many hospitals across the country, where their tax benefit, whether it's local, state, or federal, doesn't meet that same community standard, which is, by and large, one of the reasons the tax-exempt status is questioned from time to time, or quite often, actually. So again, maybe you're the model for the rest of the country or for maybe everybody else that's up here, but it's certainly a real problem for many communities across America, and that's why they get questioned. And, so I think that as we go through this process, we appreciate you being here. We appreciate all of you all and bringing forth your information, and it'll help us make better policies in the future. Thank you, Mr. Chairman. I yield back.